Again, here we go with part 2 of the urinary system. Go with red. Yeah, okay, so part 2 of the urinary system. Hopefully this will be short and sweet. Or it'll be long and torturous because I can't make it advance. Hang on. Okay. Well. Okay. So we talked about the formation of that filtrate, right? We talked about glomerular filtration rate. And that's the volume of filtrate that's formed per minute by the kidneys. And that's a really good indication of how well your kidneys are functioning. They can actually test that. There are things that they can put inside, give you an IV, called inulin, actually. Not insulin, but inulin. And they can measure how that's cleared and how quickly, how efficiently your kidneys are working. So how do we regulate GFR? I don't know why this isn't working. Hang on. Here we go. There we go. Sorry about that. Okay. Ta-da. Okay. Regulation of GFR, or glomerular filtration. All right, GFR is tightly controlled, okay? It's one of the most tightly controlled mechanisms that we have because we don't want to just waste water. We're trying to conserve homeostasis and keep our water balance in check because how much water we have in our body tells us how much blood we have. That directly affects blood pressure. So a lot of times people think blood pressure is a cardiovascular problem. And it can be. I'm not saying that it's not, but it also has a large renal component. The kidney is just as important, and for some people, it depends on where you went to school, can be more important in regulating blood pressure than the heart. So GFR is one of the things that you want to tightly control to control your water balance and therefore your blood pressure. People who tend to be in renal failure can also have problems with their blood pressure. So let's see. We have 2 ways to control it. We have an intrinsic and an extrinsic. That's just a fancy way of saying internal control. Okay, so auto-regulation by the kidney, a local control. And an extrinsic, or outside the kidney, basically nervous and endocrine mechanisms that help control kidney function, or GFR. The intrinsic controls are going on all the time. They maintain a nearly constant GFR all the time when your blood pressure is within normal range of 80 to 180 millimeters of mercury. So normal blood pressure range, although that's a little high, but during your normal blood pressure, it should maintain GFR. 2 things are going on, either a myogenic mechanism or something called tubuloglomerular feedback. Tubuloglomerular feedback, and that word tells you something, and I'll show you that in just a second. So myogenic. So myo, going back to 201, is anything associated with muscles. So basically this has to do with vasoconstriction and vasodilation of those arterioles. Okay? So if your blood pressure is high, then you're going to constrict the afferent arteriole. Like, why would you do that? Because you don't want to blow out your kidney. If your blood pressure is really, really high, you don't want all that blood, flying through the kidney and basically causing damage. You want to slow it down. So if you will constrict the afferent arteriole, that will slow down the amount of filtrate that's being made. That'll help you maintain a normal GFR. And it helps you from damaging the kidney. One of the long-term effects of unregulated high blood pressure is damage to the kidneys. Basically, it's just like you have a high-pressure hose, a pressure washer, going right through your kidneys. It's basically blowing out your kidneys, literally. So you want to try to avoid that effect. If the blood pressure is too low, you want to dilate the afferent arteriole, let more blood in, okay, so that you can have raise up the GFR. All right. So here's my afferent arteriole, blood's going in, filtrate's being formed, and the blood is exiting. Now, tubuloglomerular feedback. That means tubulo, that's the tubule, and the glomerulus. The tubule and the glomerulus are some kind of a feedback going on. And where that goes on, this is the ascending limb of the loop of Henle right here. Each nephron comes back on its own glomerulus. So it goes, you have the Bowman's capsule or the glomerular capsule, proximal convoluted tubule, loop of Henle, and then the distal convoluted tubule. The loop of Henle comes back to its own glomerulus and basically kind of comes between where the afferent and efferent arteriole come together. There's a specialized area, and these are called the macula densa cells. Okay? And so there's a feedback. These are actually little chemoreceptor cells that measure the amount of sodium that's in the filtrate, or at this point, almost the urine that's being formed at that point, how much sodium is in there. And that lets the kidney know, or lets the glomerulus know, do we need to increase our GFR? Do we need to decrease our GFR? Do we need to speed up filtration? Do we need to slow down filtration? And that's called tubuloglomerular feedback. So let's go forward and talk about what's called the JGA, or the juxtaglomerular apparatus. And I don't know what your instructor will have you learn it as. Anybody that says it enough says JGA, but that stands for juxtaglomerular apparatus. I haven't said juxtaglomerular in a long time. I just say JGA. But know what it means in case that's on your exam and not JGA. All right, you have one per nephron, and it's just an internal way of regulating the filtrate formation. You have that modified portion of the ascending limb of the loop of Henle and your afferent arteriole. You have some cells called granular cells that make renin. All right, you have the macula densa, which again are those little cells that are part of the ascending limb, and they're chemoreceptors that sense the sodium chloride content of the filtrate. And then you have these little mesangial cells. Let me go back. These are the mesangial cells, and that's the way to get the signal. They're basically the little bridge to get the signal from here to here. Here's the macula densa. These are the granular cells lining the outside of the afferent arteriole. And so these mesangial cells allow you to get your signal back and forth. Okay, so what happens? It's basically dependent on flow. Okay, it's a flow-dependent mechanism. As your GFR increases, that means you're making more filtrate, right? That means the filtrate's going through faster. You're pushing more stuff through the kidneys, more fluid through the filtrate. Because it's going so fast, you don't have enough time to absorb a lot of sodium. So it's basically flying through there with not enough time to suck that sodium back in, to reabsorb it. So because of that, your filtrate concentration of sodium chloride will be high. Okay, so it's rushing through there, and you're basically spilling out sodium. You're going to wind up peeing it out. So that's what's going on. And your macula densa cells go, whoa, whoa, whoa. There's too much sodium in there. We need to slow things down. So the macula densa cells are going to respond to that increased sodium chloride by releasing a vasoconstrictor chemical on the afferent arteriole that will lower GFR, slow it down, give more time for sodium to be reabsorbed. Okay? Opposite happens if GFR decreases. So it's just a feedback mechanism. So it's in the macula densa are measuring sodium concentrations and then feeding back to the afferent arteriole to cause vasoconstriction or vasodilation to increase or decrease GFR so that you can regulate how much sodium chloride you're spilling into the urine. Now, normally, your renal blood vessels are dilated, and these renal autoregulation mechanisms are prevailing. You've got the myogenic reflexes and the tubuloglomerular feedback are doing all that they need to do. You don't really need to do anything else, taking care of everything. But what happens if you have some kind of stress? Okay, so stress, sympathetic nervous system. What happens is norepinephrine is released by the sympathetic nervous system, epinephrine by the adrenal medulla, and they cause constriction of the afferent arteriole, and that will inhibit filtration and trigger the release of renin. So if you have a sympathetic event, okay, then you're going to have norepinephrine, epinephrine, constrict that afferent arteriole, decrease GFR, and cause renin to be released. What's renin? And I've got a nice slide to put all this together in just a second. So what kind of stressful situation am I talking about? something that causes your blood pressure to drop, okay, a low blood pressure. Your blood pressure's gone below 80 millimeters of mercury, you need to bring it back up. So one thing you could do would be to hold on to water, increase your blood volume, right? Okay, so what happens is those granular cells release renin. Renin causes angiotensinogen to be cleaved into angiotensin. Then angiotensin converting enzyme converts angiotensin 1 to angiotensin 2. And this is what we're looking for. Angiotensin 2 is what does the work. Renin just is part of the cascade. So angiotensin 2, a lot of times you're going to see it written or even said, especially in medical journals, as A2. So A2 constricts the arteriolar smooth muscle. Okay, so if you constrict arterioles, what happens? Blood pressure rises. Mean arterial pressure is going to go up. Angiotensin 2 also stimulates the reabsorption of sodium. Okay, so you're causing blood pressure to go up by increasing resistance, right? You're causing blood pressure to go up because you're reabsorbing sodium. If you're reabsorbing sodium in the tubules, you're bringing in more water, right? You're holding in more water, so your blood volume's going up, so you're increasing your blood pressure, all right? It also, the way it increases the reabsorption of sodium, it also triggers the release of aldosterone. Aldosterone is a hormone that causes you to hold on to sodium, hold on to water, increase blood pressure. It also stimulates the hypothalamus to release antidiuretic hormone. So if you're antidiuresing, then you're not making urine, you're holding on to water, right? It activates your thirst center so that you'll bring in more fluid. So all these things that angiotensin does helps to increase your blood pressure. All right. It also constricts the efferent arterioles, okay, so it which increases fluid reabsorption, and it causes those glomerular mesangial cells. Remember those mesangial cells that are inside the glomerulus? They will constrict and decrease the surface area. So all of those things work together to increase your blood pressure back up. So this is a nice slide that has everything on there that we've talked about. So we'll review it just real quickly, but this would be a great way to kind of test yourself and study because it's all here for you. It's in your book, Figure 25-2 in the old textbook. I'm not sure about the new textbook, if you have the new version. If this is your trigger, okay, is low systemic blood pressure. So you can either use an intrinsic mechanism or an extrinsic mechanism to bring your blood pressure back up. So one thing, if your blood pressure is low, that means your GFR is low, right? So what you're going to do is vasodilate those afferent arterioles to increase your filtration rate, all right? If you have a low GFR, you can also, that will cause you to have a low amount of sodium chloride in the ascending limb of the lipid family. That will feed back to maculadensa cells, which will cause, again, vasodilation, afferent arterioles, increased GFR. Now what happens over here in your hormonal mechanisms? Low blood pressure, you get the release of renin. Renin causes that cascade to occur. You get the formation of angiotensin 2, which acts on the adrenal cortex, and on the arterioles you get vasoconstriction to increase peripheral resistance, increase blood pressure. You get aldosterone, which just causes the reabsorption of sodium, water follows sodium, increased blood volume, increased blood pressure. So that kind of gives you an idea of how all those are working together. So that's what's going on. So you can see the kidney does play a fairly important role in blood pressure. It's not just for making urine. It has other roles as well. If you have any questions, please feel free to talk to me or any of your instructors. It's a complicated process, but hopefully by this time you can add what you learned in cardiovascular, what you learned in endocrine, and then tie that together with what you've learned in urinary and understand a little bit more about homeostasis and the control of blood pressure. Got some more stuff to talk about. I'm going to take a break now and come back with another presentation. So see you soon.